really just one big topic that has lots of different pieces. Okay. And, so this slide and the next slide really present the same information. They just present it in different ways. So if you feel like there's some repetition as we go from one to another, it's because there is. We're talking about the same system. We're just looking at it in two different ways. Okay, so as we sort of got a little glimpse of in the endocrine system, way back when we started, back in January, hormones work primarily by stimulation and inhibition from other hormones. Okay, so the endocrine system is very tightly integrated. And the hypothalamus, being the master of all hormones, plays the not the primary role, but it's what initiates things. It's what gets things started in the first place. Okay, so just like we saw in the male, the hypothalamic hormone that triggers the reproductive system hormone changes is GnRH, so gonadotropin releasing hormone. So this is gonadotropin, tropin is to activate. So this is a releasing hormone that activates the hormones that activate the gonads, right? So it's always weird like that with the hypothalamus because it stimulates other glands to release hormones that then actually do things. So you get releasing hormones out of that. And while GnRH may seem like, an esoteric little hormone that you won't do much with, it used to be like that. Today, there are a number of treatments for a number of disorders of the reproductive system that target GnRH, gonadotropin releasing hormone. So, for example, there's a treatment for endometriosis, that being the presence of endometrial tissue somewhere other than the uterus, which is a very common female reproductive system disorder. But there is a treatment for that blocks GnRH. It's called Lupron, and it's essentially a way to shut down the female hormonal system for a time so that the endometrial tissue will go away. It's the idea, is that it will disintegrate and not grow back. So because of that, you do need to know what GnRH is. And it sits here at the top of this axis between the hypothalamus and the rest of the reproductive system hormones. But in the normal case, so GnRH is produced. We'll start there. That occurs at the beginning of what will become the next ovarian cycle. Okay, so at the end of the last ovarian cycle, the corpus luteum has disappeared, so the ovary is essentially dormant for a time. Not for very long, just for a couple of days. But during that time, there's no release of progesterone from the ovary anymore, so this inhibition, which is shown in blue in our diagram here, is released. When this stops, when the secretion of progesterone stops, it lifts the inhibition from GnRH, and GnRH is then produced. Okay, it travels down into the anterior pituitary, and it stimulates the production of two different hormones, follicle-stimulating hormone and luteinizing hormone. Now, if you look at these two boxes, they are the production of and the secretion of have been separated in this diagram. And that's because luteinizing hormone in the female plays a timed role. In other words, luteinizing hormone has to be present in large amounts for just a short amount of time to trigger ovulation. So GnRH triggers or supports its production, but its release is delayed. Its secretion is delayed. Okay, everybody see that? So even though it's being produced, it's not being secreted. FSH, however, is both produced and secreted under the stimulation of gonadotropin-releasing hormone. All right, so what does FSH do? FSH travels to the ovary, and it stimulates follicle development. FSH is follicle-stimulating hormone. So this one tells you what it does, right? It stimulates follicles. What does that mean? It means that one of those primary oocytes that has existed in kind of stasis since before the baby girl was born is activated to become first a secondary oocyte and then a mature ovum at the end. And that happens in the ovarian follicles, which is what we talked about here. So one of these primary oocytes is stimulated, It forms this little buffer zone around it. This is a follicle, the oocyte and its buffer zone. Eventually, it forms this tertiary follicle where we have this fluid in here that's very, very high in estrogen. So that's what follicle-stimulating hormone does, is it stimulates follicular development. In other words, it readies an ovum for ovulation, all right? So FSH does that. Now, as this follicle develops, it does more than just create a secondary oocyte and a mature ovum. It also produces hormones. In particular, the follicle secretes inhibin and estrogen. Okay? Inhibin's role is to provide negative feedback to FSH. So, as the follicle gets larger, it produces more and more inhibin, which turns down FSH. This is smart because if FSH were to stay high, you might have more than one follicle that developed at a time, which for the human being is not good because the uterus is really only big enough for one offspring at a time. Okay, yes, humans can do twins, triplets, quadruplets, all that, but the risk to the fetus goes up and up and up the more babies you have at one time. You know, so like the octuplet thing that was all the rage many years ago, many obstetricians felt like that was malpractice because the chances for those babies to do well were very, very low because they all came out so small, but that's the side point. Okay, so as the follicle develops, it sends a signal back to the pituitary that it is developing and turns that FSH down. Okay, so that is that little loop. FSH triggers follicular development, inhibin is made, which turns that FSH back off. The follicle continues to develop, though. You know, once it starts, it continues to develop even as FSH levels start to fall, which is what we see here. As the secondary follicle develops, inhibin's released, and that blocks that. Okay. Now, the follicle also releases estrogens, particularly a specific estrogen, estradiol. Estrogen is several different compounds. Okay, it's actually a class of hormone. One of them is estradiol, and estradiol is the prominent hormone prior to ovulation. Okay, so pre-ovulation, estradiol levels are high, and estradiol is an estrogen. Now, the estrogen plays two different roles depending upon when in the cycle we look at it. That's one way to look at it. Another way is depending on its level. So estrogens in small amounts work as an inhibitor of LH secretion. Okay, that's this blue line here. So when do we have that? Well, we have estrogens in small amounts when the follicle is developing but isn't fully developed. Okay, so if you remember that luteinizing hormone is going to be the trigger for ovulation, well, that ovulation event needs to be timed so that the ovum is mature when it occurs. Otherwise, that oocyte isn't fertile, and it's a wasted ovulation, so to speak. You know, the body doesn't waste anything. Okay, so in the early stages of follicular development, in other words, in these stages right here, this one, and this one, estrogen levels, they're present, but they're relatively low, so estrogen inhibits the secretion of LH. Now, as that follicle reaches its final structure, that tertiary follicle that's ready to rupture, estrogen levels go way up, okay, and that's around day 10, and estrogen in high amounts actually stimulates the secretion of luteinizing hormone. Okay, and I'll have some graphs of this in a minute. So early on, it's inhibitory, but then as there gets to be a lot of it, it becomes stimulatory. So when estrogen levels get high enough, that's a signal that that follicle is fully developed. And inside that follicle is now an ovum that's fully developed. So we're ready for ovulation. So eventually, that high level of estrogen triggers a sudden surge of luteinizing hormone secretion. And it really is profound. It goes from very low to spike to very high, and then it drops very rapidly after that. Well, that LH spike triggers the follicle to rupture. So that's the event that we call ovulation. It is very, very predictable. So it's about, they say it in here, yeah, it's about 9 hours after the LH level starts to go up that ovulation occurs. And for the female not on any reproductive hormones, her fertility window, so to speak, for that month begins then, because now there's an egg in play, right? So when you toddle off to Walgreens and get your handy-dandy ovulation predictor, what it's detecting is LH. So when that LH appears in urine, you know that the fertility window begins about 9 hours after that. And then it extends, people argue about this, but it extends at least a week after that, maybe more. And you also have to remember that sperm can live in the female reproductive tract for up to 3 or 4 days. So even if intercourse was several days before ovulation, pregnancy can still occur because there's an egg in play and there's still sperm in play. So the timing game is not as precise as sometimes people would like it to be, but that's just the bottom line about it. Okay, so LH triggers ovulation. Ovulation looks like this right here. It really is kind of an explosive affair. The egg pops out through the capsule of the ovary, and of course surrounding this whole region are the fimbria of the uterine tubes, right? So ovulation typically occurs up here, and the egg pops out and then heads on its way down to the uterus. Okay. So that gets us to here. Secretion of LH causes ovulation. It triggers the final completion of meiosis. That should actually be meiosis 2. There's some errors in the book, but I keep submitting them. They haven't changed it yet. So that triggers ovulation. And then after ovulation, that follicle becomes one of these, a corpus luteum. So one way to look at the corpus luteum is this ruptured follicle heals, right? Because everything in the body heals, mostly. And what remains transforms into a very different looking gland called the corpus luteum. And the corpus luteum produces a little bit of estrogen, but it principally produces progesterone in vast amounts. So if you look at hormones across the ovarian cycle, first you see estrogens appear, and then estrogens fall, and then you see progesterone appear as we go from follicle to corpus luteum after ovulation. So that's another way you can identify when ovulation occurred, is by looking at estrogen and progesterone. But it's not as, you can't identify the spot in time as quickly as you can with LH. Okay, so now we have this corpus luteum producing progesterone. Progesterone also has effects on the hypothalamus. So progesterone, you see this blue line here, inhibits the release of gonadotropin-releasing hormone. So it tells the hypothalamus enough for this cycle, okay? Because GnRH stimulates the first half of the female reproductive cycle, and that's to develop an ovum, release that ovum. The second half of the female reproductive cycle has to do with preparing for pregnancy, okay? So that's what progesterone does. So it turns off the stimulation for new follicles, and instead, progesterone stimulates the endometrium to grow and become secretory so that the endometrium is ready should a fertilized egg implant and form a placenta. Okay, so after ovulation, progesterone levels go up, as I'll show you in a moment. Now, these estrogens and progesterones, these are also the principal female sexual hormones too. So they do a bunch of other things. So progesterone certainly has a role in the preparation for pregnancy. Estrogen does a bunch of other things. Okay, so estrogen has effects on the central nervous system, which are still being studied. But if anybody in here been pregnant, I guess I won't ask that. If you've been pregnant, many people will say there is a change in thinking that goes with pregnancy, and in part it's because during pregnancy the estrogen levels are very high. So it's not that people get dumber, I won't say that, but women will say they have more difficulty keeping track of things and more difficulty with complex cognitive tasks when estrogen levels are very high. Talk to your moms about that. You know, they call it the silliness of pregnancy or the dumbness of pregnancy. I don't think it's like that. It's effects of estrogen at high levels. Estrogen also keeps bones strong, and it stimulates muscle growth. So, you know, testosterone is famous for this, but estrogen does it too. It just does it differently. So, like, female bones are more compact and flexible, so their strength is in their flexibility. Male bones tend to be heavier and less flexible, so you have that classic trade-off between bend with the blow and resist the blow. So estrogen does things differently. Also, female muscle mass, you know, gram for gram often has more contraction strength than male. So it's not all about who's got the most muscle mass. It's how well that mass works, too. So you have that. When estrogens start to decline at menopause, you lose this effect. So you see this come up in osteoporosis. So women have trouble with softer bones when the estrogens are no longer present. It's one of the reasons why many women after menopause are on estrogen replacement therapy. It's a balancing act. You get some bad risks and you get some good things. One of the good things you get is that bones stay strong. Okay. There's no substitute, though, for it's in the reproductive years that women store the most calcium in their bones. You know, so like all of you should be sure you're getting enough calcium in your diet, because after those years, it's very hard to put calcium in the bones. Okay, so the bones you have when menopause happens are the bones you have for the rest of your life. It's also important to stay active in both times of life. Okay, so we have bone and muscle growth. The female secondary sexual characteristics, these are the things that are different between men and women that have nothing directly to do with reproduction. So body hair distribution, vocal tone, all the same things we talked about with the male. You've heard about those in other classes. Estrogens are necessary to maintain the reproductive system. So if you remove the ovaries from a woman, the uterus will eventually atrophy to the point that it's no longer fertile, even if you could implant an egg in there. So without estrogen, the ducts and tracts sort of atrophy and become non-functional. And then, as we talked about last time, both estrogen and progesterone support endometrial growth, that's estrogen, and secretion, that's progesterone. All right, so we have all these complicated things. Now, we're going to talk more about birth control methods in a minute, but this blue line right here has become one of the most common ways of affecting a woman's fertility, and that's using a progesterone, low levels of progesterone given all the time, block the release of gonadotropin-releasing hormone, which means no FSH, which means no follicle development, no ovulation. No ovulation, no fertility, right? That's why hormonal birth control methods are so effective, is because they actually block the release of the egg in the first place. So if there's no egg, there's nothing to make an embryo. So that's one of the common ones. There are other methods of affecting this system, which we'll talk about later, like the more traditional birth control pills that, you know, there's 21 days with estrogen and progesterone, 7 days off, and so on. All right, we'll talk more about that in a minute. So we have this complex interaction of stimulation and inhibition, right, that results in this timed cycle. Yes?
Okay, I have a couple questions.
Yeah.
So is there anything that inhibits the production of LH since there's no blue lines for production, or is it produced all the time?
No, LH is only produced when GnRH is around. So this blue line effectively shuts off LH2.
So it just stays there until it's...
Yeah, LH is produced, then it's secreted, and once the GnRH drops, LH production falls.
Okay.
Does that kind of make sense?
Yeah.
Yeah.
And then one other question, how can FSH release an inhibitory hormone that inhibits itself? Like how it releases inhibin and then it inhibits itself?
Here?
Yeah.
Well, that's what you usually see, though. FSH stimulates the follicle to develop. The follicle makes inhibin, which then turns FSH off.
Oh, the follicle makes it.
Right. So once the follicle's big enough, FSH isn't really needed anymore. So it sends the signal that it's done.
Okay.
And then it turns off. Good. Good. You're thinking that through. Good. All right. Okay, so if we put that pattern of stimulation and inhibition, if we put it over time, okay, we can look at the different cycles sort of all at once and the hormones in play. All right, so hopefully you've learned from me by now that whenever you see a complicated graph, first figure out what you're looking at, right? Identify the axes and the boxes. So the x-axis is time, okay? So we have day 0 to day 28. Typically, we define day 0 as the beginning of menstruation. Now, it depends on which field you're in as to where they define 0. Sometimes it's the end of menstruation. In reproductive clinics, they do it by ovulation, so you just got to figure out what standard they're using. But we're going to go 0 to 28 from the beginning of menstruation to to that same point on the other end, right? Okay, so then we have the boxes. So this top box is what's happening in the pituitary. Okay, so these are pituitary hormones. GnRH is not in this, okay, because it's either on or off based on whether there's progesterone present. So we start here. Here's the pituitary hormones. Here's what's happening in the ovary. Here is what's happening from hormones from the ovary. So these are variant hormones. This is what's happening in the endometrium, and then this is an interesting point. This is basal body temperature. Now, you may not know what that is. Basal body temperature is your temperature first thing in the morning. And for practically everyone, that is your lowest body temperature during the day, is first thing in the morning. Why? Some of it's just due to inactivity. You know, your muscles have been relatively relaxed for many hours. Muscles produce a lot of heat. So, you know, you haven't been generating as much heat as you usually do. Plus, the circadian rhythm that's set by the pineal gland also changes temperature throughout the day, too. So this is basal body temperature, temperature first thing in the morning. And what you'll see is that it goes up by about a degree immediately following ovulation. This is an old school way to predict ovulation and fertility. So many of you will have heard of the rhythm method of birth control. It always involves measuring something every day that will tell the woman where she is in her fertility window. So like this would be an infertile time, this would be a fertile time, right? So that's I think why they put that in here. Okay, so let's look at the pattern. Okay, so we start and all the hormones are low. Right? FSH is low, LH is low, estrogen, inhibin, and progesterone. So estrogen's in red, inhibin's in blue, progesterone's in black. LH is in pink, and FSH is in blue. Okay? Why are they all low? Because we are at the GnRH has been inhibited by the existence of progesterone, and both FSH and LH are low, and there's no follicle yet. Right? The previous follicle became a corpus luteum, disappeared, so the ovary is resting, you could say, at the beginning of the cycle here. Okay. Well, that doesn't go on for very long. Okay, so as the progesterone levels fall at the end of the last cycle, FSH levels start to rise. Do you see that here? As this is going down, this blue line is going up. Okay, so as FSH rises, it stimulates a follicle to begin to develop. So this follicle starts, primary, secondary, tertiary follicle development. As it develops, it secretes more and more estrogen. You see that? And as it gets very close to being completely formed, it secretes inhibin. And as inhibin goes up, do you see how FSH goes down at that same time, like we just talked about? So inhibin inhibits FSH. Okay. Estrogens, however, are going up. And remember, estrogens in low amounts inhibit luteinizing hormone. That's this flat right here. But as estrogens get very high, stimulates LH hormone release. So when the follicle is finished developing, its estrogen levels skyrocket. You see that here. That triggers luteinizing hormone to be released. And then luteinizing hormone triggers ovulation. Okay, so this is that LH spike that I talked about. So see how it's a good ovulation predictor? It's low, 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 super high, low, 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 low again. So the only time you find luteinizing hormone in urine is when ovulation either is near either it's happening soon or it has recently happened. So it is a good fertility predictor. All right. LH causes this ovulation event to occur. So this follicle that has been making estrogen, it ruptures. When it ruptures, it doesn't produce estrogen very well because it's broken, right? So the estrogen levels start to fall. And as it transforms into a corpus luteum, we see the progesterone levels go up and up and up. The progesterone here is inhibiting GnRH and therefore keeping LH and FSH both low, right? Because the way the female or the human system, well, all male system is set up, one of the reasons it's like this is to prevent pregnancies at multiple times. You know, imagine if you were 3 months pregnant and then you got pregnant again. Well, now you've got this problem because how are you going to deliver the baby, right? You're going to have one early and one late or something like that. So the reproductive systems in all the mammals it's all about timing to prevent stuff like that from happening so that there's only a narrow window of fertility going forward. Okay. So progesterone goes up as this guy gets bigger. If there's no pregnancy, we'll talk about what happens if there is in the next section when we get there. But if there's no pregnancy, which is what occurs most of the time, this mature corpus luteum producing progesterone, a little bit of estrogen, and a lot of inhibin, okay, eventually it disappears, it involutes, they say, and it becomes what's called a corpus albicans, which is just a dying corpus luteum. And as it scars down and becomes non-existent, the hormones it produces fall off, right? So inhibin goes down, progesterone goes down, and estrogen goes down. This is probably the cause for the premenstrual syndrome, which many of you will have heard of, is because about a week before menses occurs, we get 3 plummeting hormones, 2 of which have effects on the central nervous system. The progesterone and the estrogen both affect things like mood, thought patterns, things like that. So it isn't a surprise that there's a change in mental behavior because of these dropping hormones, right? Okay. So as those things fall off, the corpus albicans is disappearing, they're falling off, and when the progesterone drops, the FSH starts to go up, and now we're ready to do this whole thing again, right? So the next follicle is stimulated to develop. There's ovulation, corpus luteum, it disappears, round and round it goes for 30 years, right? From 12 to 15 to 45 to 50, depending on all the gene stuff. Okay, so given this is all you need to worry about. Estrogen, the ovarian hormones are what control this box. This is what's happening in the endometrium. These control this. This makes this, right? All of these hormones are produced in these structures, right? And it's these hormones that then affect what's happening in the endometrium. Okay, so we'll start at the beginning, and the end, so to speak. All right, so the progesterone is falling, the estrogen is falling. The endometrial tissue has been built up and made secretory by these hormones over the cycle. When they disappear, the tissue they made disappears. Okay, now, of course, nothing just disappears. It falls apart. And when it falls apart, it drains through the cervix as the menses, right? So in that week, they give it 7 days here, the endometrium falls apart. Here are those spiral arteries. They shrink down, right? So they're ready to supply the next tissue when it grows. That's what these red spirals are. Spiral arteries shrink. the endometrial tissue disintegrates. Not all of it. The basilar zone is still there, but the functional zone disappears. Okay, and then about that time, the next follicle is starting to develop. So estrogen levels are going up. Estrogen causes the endometrium to thicken. We call that the proliferative phase because it's getting thicker. Then in comes progesterone because ovulation has occurred. Now there's a corpus luteum. And progesterone makes this tissue more secretory so that it has more glands, it produces more fluid, it produces more nutrients for the implanting embryo, which we'll get to when we get to what happens if pregnancy occurs later on. Okay? Until we get all the way to the end, when the corpus luteum disappears, progesterone, estrogen fall off, and we repeat the cycle again. Okay, so if I had to make a center for this, what is the pivoting part of the whole thing? It's what's happening in the ovary is really what drives the rest of these pieces. And what happens there is a follicle develops, ovulation occurs, what's left becomes a corpus luteum, which behaves differently than the follicle, which also eventually disappears if there's no pregnancy. All right, so questions about those complicated things? You're either fully aware or lost, right? Who's lost? Oh, that's encouraging. Nobody's lost. Okay, good. So there are, my next slide is birth control strategies. So these systems interact, right? That's what this slide shows. Progesterone inhibits GnRH. Estrogen, in low amounts, right, inhibits LH, which therefore inhibits ovulation. So there's a couple of places where this hormonal system has been targeted to control fertility, right? That's the birth control pill. The technical way to say it is it's fertility control. So estrogen and progesterone are super easy to make. And even before they were easy to make, they were easy to find because mammals of all types produce estrogen and progesterone. So it's easy to get these things. So they were made into birth control strategies. So I talked a little about the progesterone-only pill already. Now, it does maintain the endometrium. So like in the birth control patterns where there's 3 months between menses, let's say, or 6 months, what's happening is the tissue just stays like this. And sometimes women will ask, well, isn't that a problem? That's not natural, is what you hear sometimes. And it's fine. This is perfectly healthy tissue. The endometrium, if there's a pregnancy, it will stay like that for 9 months. So it's fine. It can stay like that for a time. It's thicker than it is when it's at its smallest, but it's also healthy. So even though we have changed the pattern with the medication, we haven't caused some problem. Like there's no increased incidence of endometrial cancer, for example, on the every 3 month or every 6 month menses plan. And typically that's done with progesterone. But estrogen is found in birth control pills too, for 2 reasons. One is for some women, progesterone only has mood effects. Women don't like how they feel on progesterone only pills, not all, but some. And it's because of estrogen's effects on the central nervous system. If you just have progesterone, okay, it's going to inhibit GnRH, which is going to inhibit FSH, inhibit follicle development. Follicles are where estrogen comes from. So if you give women just progesterone, over time their estrogen levels fall and they stay low, and a lot of women don't like how that feels. So one of the common approaches to this is progesterone is used to manage the reproductive system. Estrogen is added to keep things more normal, right? So that the estrogen level is more in the normal range. Because the body can't tell the difference. As long as there's plenty of progesterone, there won't be any FSH, so there won't be a developing follicle. So then the estrogen is added back in for its other causes. So it's not the estrogen that's controlling fertility, it's the progesterone that is. Long time ago, when they first came out with birth control pills, they had massive doses of hormones compared to what they are today. So when you read studies from a long time ago that birth control pills have all of these side effects, increased risk for cancer, breast cancer, all those things, those are still maybe true, but they're not nearly as true as they used to be. Modern birth control pills have like a 10th or even 100th of the hormones that there were in the original ones back in the 1950s and 60s. Yeah.
Is that related to infertility too? Like that same idea?
Oh, what causes infertility?
With the use of birth control extended.
Like
with the extended use of birth control. You know how that was kind of like something that they
yes. Like there's no off switch. In other words, if you're on birth control for too long, you'll never be able to be fertile, right? Yeah, that does not play out in the population. Part of where that myth comes from is, particularly here in America, we like our switches. We want to turn on the infertility and then turn it off when we want to have a baby. And after a prolonged time on birth control pills, it takes the system a while to get back into the pattern. So some of those infertility after birth control is somebody stopped taking the pill 2 months ago and they're not pregnant, so they think they're infertile. And it just isn't like that. You've got to give it time. Most fertility experts won't even begin treating somebody until 6 months after they've been off everything, because it just takes time for the cycle to reestablish. Yeah?
So like every woman has a certain amount of like eggs, I guess, right? So if
Far more than you'll ever use.
Okay, because I was gonna ask if
You don't run out.
Okay, I was gonna ask if birth control prevents you from releasing an egg. Does that mean that somebody that's not on birth control versus somebody that is, that person will have like a lot more?
Technically, yeah. Well, you can do the math. They'll have, as however many months they were on birth control, they'll have that many more eggs still. But one common misconception is that menopause occurs when the ovary is out of eggs. That's not true. Menopause occurs because of changes in the brain, they think. So you have plenty of eggs. You have more eggs than you would ever need. But yes, there is egg conservation while you're on birth control pills. It just doesn't matter. Right. Good question. Though you're thinking it through, which is what I want to hear.
So how does birth control, like I know some people take birth control to control their acne. How does that come into play?
Because estrogen, progesterone has a tendency to make skin break out because it increases, it gets everything ready to provide for the baby. So it makes lipids and it makes carbohydrates. Those things clog pores. Estrogen does the opposite. Estrogen has a tendency to make skin firmer and more elastic, which helps to prevent the bacterial growth in there. So yes, usually it's estrogen it's an estrogen effect, clearer skin, clearer, smoother, spongier, snappier skin.
So why don't they just prescribe estrogen as opposed to using progesterone and estrogen?
Because without the progesterone, you've got no fertility blockade.
Yeah, but if they're just doing like young girls with acne.
Oh, why do they bother with the other? I don't know.
And does estrogen increase elasticity within all parts of the body or just primarily in the skin on the face?
It has effects in other places too. Like joints, for example. Again, many of you will be pregnant someday, and you'll find out that in the 3rd trimester, your joints get a little wiggly, and it's estrogen causes the ligaments to relax, so that things can stretch a little easier. So and at that time, of course, there's the big belly that mom's having to manage too. So there's become a huge fall risk.
This might sound like that question. Why don't they give this to kids when they're going through like puberty? You know how girls stretch too quickly? Like I had a roommate and she had developed like stretch marks and stuff because she shot up 8 inches within a year.
Mm-hmm.
And so why don't they maybe try that?
It's because estrogen, it has some risks associated with it. I mean, the more estrogen you're around for longer, the higher your risk of breast cancer, for example. So it's not without its troubles. Which is why they've driven down the concentrations of hormones in these pills is to try to reduce some of those risks.
Got it.
Yep. Somebody else had a question. Yeah.
What is the correlation between progesterone and migraine?
I don't know. Sorry. There could be one for sure, though. But I don't know anything about that. You got me.
Because I've read that decreased progesterone can lead to frequency of migraine. Because I always have migraine. It's because of I have low
Progesterone does have impacts on blood flow, and they think anyway that migraines are primarily a derangement in cerebral blood flow. So I see a connection there, but I don't know of anything specific. And migraines can trigger from lots of different things too. Yeah.
This is kind of trivial, but what
No such thing.
how is it that birth control pills can cut down on the amount of bleeding and also cramps?
Good
Because
question.
I know people take it just for that.
Yes. This is the natural state where you get a lot of estrogens and a lot of progesterones. It turns out that when you give hormones from another source, the follicle, the ovary makes less. So one of the ways that effect happens is the estrogen level is kept lower. Less estrogen means less endometrium, and less progesterone because you don't need a big spike like this. You only need a little progesterone. So you can keep the whole endometrial lining thinner. Less to fall apart, less to cause inflammation, less cramping, less those things.
What is cramps? Is that that's caused by the endometrium?
Cramps are caused by, that's the uterus contracting. That's what the cramping is. Now, the uterus is smooth muscle, so it contracts. That's to help get the menses free. But the problem is the same chemicals that cause the uterus to contract affect the small and large intestine too.
Okay.
So you get contraction there too. It's not specific. Yeah.
What is the
Told you, always lots of questions.
what is the difference between birth control and then like that other like contraceptive pill? I think it's called like Plan B or something, like where it's like if you have a released egg, it somehow protects you from still getting pregnant.
There's a number of different Plan Bs, post-coital birth control. One is to hit the system real hard with hormones that disrupt the endometrium to trigger menses. And if there's menses, if there's no place for that fertilized egg to land, there's no way that pregnancy can occur. That's one approach. Another approach is to target the developing egg, which is a rapidly dividing set of cells. So it was never authorized here in America, but there was one that was given like a number, CX, something. It came from France. And what it did is target rapidly dividing cells so that the embryo would die and not implant.
Cytotec?
No, not cytotec. That's used for something different. I can't remember it. It was, RU46. Would that sound familiar to anybody? No, probably showing my age. RU486. Yeah. Anyway, it was one of the early Plan Bs. Modern American Plan Bs they affect the hormone system, and I admit I don't know exactly how they do. But the goal is to prevent implantation. No implantation, no pregnancy. Yeah.
Why do women have a low body weight not always get a regular menstrual cycle?
Complicated question. It's anovulation. So what is happening is a follicle does not develop. Therefore, there is no ovulation. Therefore, the cycle stops. So there is no menstruation either. Now, why that occurs, I don't have an easy answer for. It is not malnutrition, although malnutrition will do the same thing. I'd be guessing. So I don't want to guess. But it's very common. It's not considered abnormal either. So women who are very physically fit, get a lot of exercise, have low body weights, it's a very common problem. Yeah. And I'm not sure what the relationship to fertility is. Obviously, if you're not ovulating, you're not fertile, but I'm not sure how they address that. You know what I mean? So, boy, you stumped me twice this evening. That's this class. You guys are smart. Yeah.
You said there's no trivial questions, so I'm taking that and going with that.
Yeah.
So with all this, like with the knowledge and stuff you have about the hormones, with the birth control stuff, which birth control would you take?
if you had to choose, if, you know.
I know what you mean. I know what you mean. There's a couple of factors that play into it. One is, convenience and reliability, right? That's why I'm a big fan of the progesterone-only ones. The only thing is if it made me feel weird or if it made me, a tyrant or something like that, then I would want the estrogens too. But in terms of simple effect, the progesterone-only one is the simplest effect. And you don't have the estrogens and the risks that go with them. So that's what I would choose. Although another thing I would think about is an IUD too. It's one of those classic things where when they were first invented, they were full of problems. They caused scarring of the uterus, they caused scarring of the fallopian tubes, lots of infertility. So they got this really bad rap, that IUDs are terrible. They were even pulled off the market entirely for a time. The ones today are high-tech, well thought out, well studied, and they have a great track record. Plus, you can't forget to take the pill. You can't forget to, go in for the shot. It's reversible, and once it's in, you don't have to do anything. So you're infertile until you go and you have it removed. So that's what I would recommend to my adult patients anyway, is think about an IUD. I think the reasons people go, oh, that's terrible, one is it's invasive. You have to put it in and take it out. But it's so much better than taking a pill every day, or having to go in every 3 months and all that. So now it provides no protection from sexually transmitted diseases. But I think in the future, a lot more women are going to go with the IUD approach instead. So that would be my suggestion. I've taken care of different populations. So in a teenage girl, I usually recommend the Depo-Provera shot because you can't forget a pill. It's very effective, and you get the benefit of less frequent menses. But in a married couple where they're planning to have children 5 or 6 years later, do the IUD, and be done with it. Yeah.
So when people say they're having problems getting pregnant, is that a problem with the corpus luteum forming? Or
it can be a problem with anything.
Okay.
It can be a problem from the male end, that sperm are not fertile or sperm are not motile or their sperm production is low. It can be a problem in getting the sperm into the reproductive tract. Mom can have antibodies to dad's sperm. There can be changes in the vaginal environment that destroy the sperm before they get started. Then you get into the hormonal things, anovulation like we talked about. Low body weight is just one cause of that. High body weight's another. Polycystic ovarian disease. Estrogen and lipid have a relationship. So the more adipose tissue you have, the more estrogen you have. That can block ovulation too. So you get the hormonal side, then you have implantation problems. So if there could be a problem preventing the egg from implanting in the first place. So there's oodles of problems.
Would there ever be
a fertility workup usually takes 3 months or more.
Would there ever be a way that, very rarely, that if someone was if a woman was so infertile, she never had a period?
Mm-hmm.
Can that ever happen?
Oh yeah, that happens. That's if the ovaries didn't form right. That's exactly what will happen. Because no ovaries, no this, and no this. So you're infertile from the get-go. There's a couple of genetic disorders that will cause that. And usually if menarche, which is the beginning of menses, hasn't occurred by 18, you start working patients up for that. First you find out if they have ovaries at all, and then you go from there. Yeah. All right, we're out of time. We kind of talked about these already, but I'll pick up here next time because there'll be more questions.